Very good evening to all of you. I welcome you all for the second session of the movement disorder SIG. And today we have an interesting talk on genomics of movement disorders by Dr. Vinod Skaria. I request our President, Dr. Shafali Gulati, to introduce the speakers and experts for today's session. Over to you, ma'am.
Thanks, Mahesh. I welcome you all to this next webinar. And Smita, can I have the CV slide, please? Last week we've had wonderful cases of movement disorders, and we were learning through cases. Genomics is very important these days, and very importantly in movement disorders. And we'll have a talk on genomics in movement disorder by a dear friend, a physician scientist, Dr. Vinod Skaria, who was initially in IGIB, and now he's senior consultant in Vishwanath Cancer Care Foundation, Bangalore, and adjunct professor, India Institute of Technology, Kanpur. And he has over 200 plus publications, and on wonderful, he's written so many articles and got so many awards, and really grateful to him. And we've had a lot of sessions from him when we had the neurogenomics part last year, and what the experts to say. Thank you so much, Vinod. And take the discussion forward. We have three experts and three very eminent experts. Dr. Sanem Ilmaz, from Associate Professor from Pediatric Neurology, and was a faculty member at SIG University, Medical University in Izmir, Turkey, and has worked initially with Dr. Jonathan Mink, and her area of interest is on pediatric movement disorders and childhood epilepsies. Then we have Dr. Tajul, who is really, really very, very much interested in movement disorders and very bright. And he's a consultant pediatric neurologist and movement disorder specialist. Did a fellowship in movement disorders in US, in Rochester. And he's basically area of interest are movement disorders, autoimmune encephalitis, and neurotransmitter disorders. And we are also being joined by Dr. Vinay Goyal, who was initially, he's also a dear colleague and dear friend who was there in AIMS, and now he's left the adult neurology department and joined as Director Neurology Neurosciences Institute, Medanta, Gurugram. And he is, in addition, a fellow of Indian Academy of Neurology with the area of interest of movement disorders, in addition to stroke, Parkinson's, and neuroimmunology, and has got a lot of awards. And the moderator today would be our own Mahesh, who's the first DM pediatric neurology student of ours, and that was 20 years back that he joined us, because we started in 2004, and he's professor now in Jain Medical College, Belgaum, and he's secretary of AOC and currently along with me. And he's a really very astute clinician and a wonderful, amazing human being. Mahesh, on to you. And at the outset, before you take over, is Sangeeta there? Sangeeta want to talk about the conference. Sangeeta is there? And then you can talk about it. Okay, you can talk about it. You can do in your opening. Can you show the conference slide and you can just tell about it? Yeah, please. Yeah. And then you can give it to Vinod. Yeah.
Okay. As you all know, we're conducting our national annual conference, it is Child Neurocon 2024 in CNC Vellore. The conference will be held on 3 days, it is 8th, 9th, and 10th. 8th is the day for workshops, and 9th and 10th is a main conference. The abstract submission is open and the registration is open. Please visit the website and register in good numbers. Thank you. I'd like to request Dr. Vinod Skaria to do his presentation. And I request all the delegates to put their questions in the chat box, and they'll be taken for discussion at the end of the talk. Over to you, Dr. Vinod.
Yeah, thank you very much, Dr. Mahesh and Dr. Shafali, for organizing this session. And it's always a pleasure, as usual, to be amongst you. Well, that always comes with a caveat that I've never worked quite extensively in pediatric movement disorders, but I did some work with, in movement disorders in general, but largely affecting adult patients. But having said that, what I'm going to present here today is essentially what I call as a 2.5 story of how movement disorders could be impacted by genomics. So I'm not going to delve deeper into what genomics is, how genomic sequencing is important, etc., but I'm going to just tell 2 stories on how this genomic studies could be extremely impactful. And that's my 2.5 stories. Now, I would be preaching to the choir if I'm going to tell about what movement disorders are, what are the classes of movement disorders, what is the nomenclature for them. That's not really my purpose. I'm not a pediatric neurologist. I'm trained as a scientist, but of course with a training in clinical medicine. So I'll not rather spend time preaching to the choir. But of course, what we all know is that in 2016, there is a formal nomenclature system for genetic movement disorders that is in place. And since we talk about genomics, that is really the basis of what we all talk about. And of course, in general, there are around 7 broad classes that this nomenclature system has put together. So my point is not really to talk about the nomenclature, how to go about it, and how to go about the diagnosis. No, that's not really my point. My point is essentially to put across just a few points through 2.5 stories. And the first story is, and the background of all that I'm going to talk about is a large collaborative network that I created with my colleague, Dr. Sridhar Shivasubbu, in my former institute, the CSI Institute of Genomics and Integrative Biology. And this large network is called Guardian, and it still exists. And of course, I handed it over to junior colleagues at IGIB before I moved out almost 4.5 months ago. And this has been one of the pioneering endeavors in India to uncover genetic diseases and genomic underpinnings of genetic diseases, impacting close to around 5,000 odd people over almost a decade and a half. Now, this story essentially comes with our collaborator, Dr. Radha Mahadevan, who is a professor in neurology in one of the medical colleges, probably the southernmost medical college in our country, in a small place called Tirunelveli. And this is also a story about a decade of constant patience and perseverance. Now, the story starts way back in 2008, when Dr. Radha Mahadevan was an MD student at Madras Medical College. And further, she saw a patient which she was not very convinced of what this is. But further, after moving to Tirunelveli Medical College as a young faculty, she started seeing many more of these patients. And of course, they came with very weird presentation. And she was very persistent and perseverant to actually follow up and document every one of these single cases. And she was able to trace the first patient that she saw in 2008 in a small church in 2010. That is the Puliyampatti Church. If people are from Tamil Nadu down south would know this particular church, because a lot of destitutes, a lot of people who have rare genetic diseases which have no hope or who have no hope end up being in this church compound. And then, of course, the last part of the journey, or rather the smallest part of the journey, was at my former institute, the CSI Institute of Genomics and Integrative Biology. And this is also a story where I had the good fortune to work with a fantastic set of colleagues, Dr. Mohammad Farooq and Dr. Sridhar Shivasubbu, who has been fantastic friends, and 2 young colleagues of mine, Dr. Rahul Boyer and Arushi Batra, who extensively worked on this cohort. Now, the story starts with a set of constellation of symptoms that Dr. Radha Mahadevan observed in a very small number of individuals, starting with just 1 individual in 2008, but growing over time to half a dozen, and then further over a dozen, and then with consistent efforts to multiple dozens of such individuals. Now, the predominant clinical features could be divided into 3: myoclonus, tremors, and occasional seizures. And of course, people would have different combinations of all of this, but in a general perspective, they did have all these 3 at varying levels of penetrance. Now, over the last 1 decade, Dr. Radha Mahadevan started collecting these individuals and eventually also growing them into families of pedigrees. And as you see here, she has collected quite some extensive pedigrees of families where multiple members were affected with the same constellation of symptoms. Now, this is extremely important in clinical practice, because rarely in clinical practice, or very busy clinical practice, especially in a medical college, we do have the time and energy and the patience to actually build extensive pedigrees. But that's what Dr. Radha Mahadevan did over years, slowly, painstakingly building many of these pedigrees, some of them ranging to 4 to 5 generations in total. Now, of course, for this constellation of diseases, which is still not an official nomenclature in any one of the classification scheme, it's broadly called as familial because it occurs in family, adult onset, typically because onset is in the adulthood, but of course with a lot of exceptions. Clinical features characterized by myoclonus and epilepsy and summarized into a term called FAMI. Of course, there are multiple different variations of this particular name. Different constellations of the symptoms have been observed in different populations. Very small number of individuals, typically less than a dozen individuals in any one of these reports reported from anywhere across the world. And in terms of the genetic underpinnings, of course, a couple of them have genetic underpinnings very well documented, but very recently documented. But the others have largely been marked across chromosomes or chromosomal locus with no great understanding about what really caused this genetic disease. But largely the consensus is that since they're familial in occurrence, they could have a very strong genetic underpinning. So the first case report from India for this particular constellation was published sometime in 2016 by Dr. Radha Mahadevan, which included 240 odd patients from around 48 families. And interestingly, all these families came from one particular endogamous group. And that was really the clinching point, because as you would have seen in the earlier slide, these are extremely rare entities with a prevalence of approximately 1 in 35,000, or where the Japanese have sort of examined this because it's a very large cohort of individuals in Japan, who very large means a couple of dozen individuals in Japan who have been extensively studied, but never ranging to numbers of couples of dozens or even hundreds of individuals. So this initial case report sort of said that this is a likely autosomal dominant kind of a condition, and it is unique in a southern Indian population, but of course with no genetic underpinning known or no causality sort of established in terms of the genetics. And of course, as I stated, this is largely an adult onset disorder with a male to female ratio particularly skewed towards the male. And the age of onset, of course, could be as young as 8 years to as old as 69 years, but with a mean of approximately around 35 to 40 years. Now, all these patients belong to one socioeconomic or cultural or rather endogamous group of individuals. They could encompass multiple different professionals, and this group is far spread across southern India, and of course, the diaspora ranging across southern, eastern, and of course, across the world. Now, incidentally, a similar case report of around 4 patients were also documented from Ahmedabad, but of course, neither the clinician nor the patients could be traced during our study period. Now, for us to start, we started sometime around 2015, where we had a fortune to meet Dr. Radha Mahadevan and discuss this entire sort of disease and pedigree. We largely started with 4 pedigrees, but of course, one family we could not access the samples back, so it ended up with just 3 family pedigrees with multiple affected members. At least one family which has a very large number of affected members in at least 3 generations. Now, pedigrees and therefore the documentation of clinical information is extremely important to uncover genomic facts, especially in such undiagnosed but otherwise rare genetic conditions. So as usual, we would go ahead with a genetic test, and the cheapest, simplest genetic test that anybody could afford is to do a whole exome sequencing. We did a whole exome sequencing and indeed also a mitochondrial genome sequencing, and we could not really find anything. And in typical clinical settings or even research settings, including in our lab, it's very rare that people would be persistently following a genomic diagnosis despite having multiple negative reports. Now, in this particular case, we did sequence half a dozen of individuals. So we did a whole exome sequencing. We did an extensive bioinformatic analysis, and we practically could not get anything. We did at very large coverages. We did at multiple families, but we still could not get anything that is common or similar between them. And that was also the time when we were venturing out into doing whole genome sequencing. And of course, we did whole genome sequencing. A standard analysis did not reveal anything much. But then we had an opportune moment to actually glance through the files because we are looking for a set of genes which are involved into similar phenotypes in animal models. And we were manually looking through these files. And these are essentially the alignment files out of the whole genome. And what we found was something really remarkable. And what you see here is essentially a set of dots that you see here. The dots are essentially nucleotide variants at a particular position. And these nucleotide variants were recurring in a pattern, as you see here, every 5th or so basis. And as you see, this is very stark in here. You have these dots. At every 5th position, there is a C nucleotide compared to the reference genome. Now, this is something that is interesting. And as you see here, the patient had those dots, while the unaffected individual did not have these dots. Now, when you see these dots, for people who have been looking at genomic data, would quickly understand that this is nothing but a repeat or a repeat expansion. But because as you see here, there are multiple such 5 nucleotide Cs repeating across that particular region. Now, what this would mean is that this is a 5 nucleotide repeat expansion, which is not in an unaffected individual, but in an affected individual. So with this one single family, one single patient, we could get a hypothesis that this could probably be a repeat expansion disorder. Now, of course, there was also a time point when repeat expansion disorders or even pentanucleotide repeat expansion disorders are not very commonly known. The typical repeat expansion that people generally study are triplet repeat expansions. There are very few pentanucleotide repeat expansions ever documented in literature. And while we were looking at this data, we also came across a paper that was published just a few weeks later, documenting a pentanucleotide repeat expansion in a Japanese family with a similar looking myoclonus and epilepsy clinical feature. And what this showed is that multiple patients in multiple kindreds do have this repeat expansion or a pentanucleotide repeat expansion. And they could go back and do sample sequencing to prove that the triplet repeat expansion is exclusively present in the patients and not in the unaffected individuals or in the population controls. So that's exactly what we also quickly went and did. We built a very cost-effective or cheap assay tool to look at these repeats, and this is something called a repeat primed polymerase reaction. It's essentially a PCR reaction. And since one of the primer binds to the repeat and the other one does not bind to the repeat, you could have copies of such fragments, each of them having a repeat and spanning into the non-repeat region. And depending upon the number of repeats, you can run it on a gel electrophoresis or for that matter, a single capillary electrophoresis. And you could read the number of peaks, and the number of peaks roughly corresponds to the number of repeats. So as you see here, you would see that normal individuals do not have repeat expansions at that particular locus, but patients do have multiple repeat expansions. Of course, the upper limit of this repeat expansions we could not look at because it is crossing over 70 to 100, and you cannot really count using this technique at the high resolution of repeat expansion. But nevertheless, the repeat expansions were exclusively present only in the patients, but not in the control individuals. Now that you have a very cost-effective tool, what you would go is to go back to the population, collect as much number of samples, affected and unaffected, and now use this as a screening tool because now it becomes a very cheap, affordable, accessible resource and can be run in resource-poor conditions and therefore can be used for screening. And that's what we did over the next few years. And what we uncovered was something that we never ever expected to come across. What we uncovered was a patient load of approximately 700 odd patients from a single population group in southern India who could now be screened with this very specific, very accurate, cheap, affordable, and accessible genetic test to fall into the category of a new genetic disorder, what we call as the familial adult onset myoclonic epilepsy, with a pentanucleotide repeat expansion, making it one of the largest cohorts for this particular disorder documented anywhere across the world. Now, after we published these papers, of course, there have been publications from multiple other countries, including a large cohort from Australia, some individuals from Malaysia, some individuals from Indonesia, but all of them having a common ancestry pointing to this common root or the common endogamous population. Now, like I said, this small endogamous population has spanned wide across southern India and also has a diaspora spanning across Southeast Asia, the United States, and the Europe. And today, with the extended family, can now access, because in autosomal dominant condition, there are many more family members who could now access this extremely cost-effective, accessible genetic test. So from the first clinical report in 2016, or rather the first report in 2008, documentation in 2008 to 2018, in a decade's time, we could uncover probably a very large burden of this genetic disorder, which still does not exist in textbooks. Now, of course, this is another story, and this story, of course, did not come from a doctor. This came from an ex-MLA, sitting MLA during that period of time, Mr. Harshvardhan Sabkal, who was an MLA from a small place called Buldana. Buldana is a district in Maharashtra, a small town. And what Mr. Sabkal came to us was with a lot of documentation written by lawyers, because one of the prominent lawyers in that particular community has sort of painstakingly created documents, a 200-page document, describing people around him. And what these people around him had was ataxia, of course, a movement disorder, and with no diagnosis, and there are multiple individuals affected with this particular disorder. And what Mr. Sabkal pointed us to was a small village in a place called Buldana. And Buldana is quite close to Nashik and Aurangabad. It's a small place. And we did have a fortune to go to this community and talk to people from this community. And what they say is that there is some disorder running in the community. There are members who get ataxia at a middle age or an older age, and eventually they get bedridden or incapacitated. But increasingly over the last decade or a decade and a half, there have been many young individuals, including children, who become affected. Now, in genomics, what you do is this is clear-cut case of ataxia. Of course, as clinicians, you could classify it as spinocerebellar ataxia. We did a genomic study, and what we identified was a new class, not really new class, hitherto unknown large population of SCA3, or otherwise called Marshall-Joseph disease. We could screen approximately around 200 odd families in the small village in Buldana with spinocerebellar ataxia type 3. And the diaspora includes quite some diverse professions, right from farmers to ex-army professionals to even children and athletes who are all incapacitated with this particular disease. Now, to put numbers into perspective, SCA3 was until then considered to be an extremely rare entity in India. In fact, there have been publications which have been written upon it to state that while it is a predominant type of ataxia elsewhere in the world, especially in the Latin America and Europe, it has been an extremely rare entity in India. Even in the large cohort studies from the All India Institute of Medical Sciences or from NIMHANS, they have been rarely categorized as SCA3, while much commoner varieties, including SCA12, have been very widely documented across the country. Now, a very recent publication from my colleague, Dr. Mohammed Farooq, takes it as the top third class of spinocerebellar ataxias after SCA2 as SCA3. And that would necessarily mean that there is a lot of hidden burden for this genetic disease in India. And that boils to a very, very fundamental question on when we talk about rare genetic diseases. We all talk about rare diseases because they're rare to start with when they come to the hospital. Now, what is really rare? And if you ask this question to different people, you will find different answers. If you ask this question to a neurologist might say a rare disease is probably muscular dystrophy or epileptic encephalopathy, or for that matter, it could be an inborn error of metabolism. If you ask this question to a cardiologist would say sudden cardiac death, or for that matter, cardiac channelopathies. If you ask this question to a pediatrician would probably say people dying out of infections, primary immunodeficiency might be a rare disease. If you ask this to a neurologist or a neurosurgeon, they would say multiple endocrine neoplasia would be a rare disease. Now, we should all understand that while we are all good clinicians, we all see rare diseases which come to us, right? Because that's a basic premise of modern medicine, that patients would come to the hospital with a genetic disease. And then, given our knowledge and our acumen, we do diagnosis of these conditions and club them and put them into a number, which eventually translates to the rate of this disease in different populations. Now, we should assume with the basic premise that not all patients are diagnosable, or in other words, therefore, all estimates of genetic prevalence or genetic disease prevalence in the population can be very well off the chart. And then that boils to the question of then how can we really estimate what is really prevalent in the population? And to me, the only answer to that question is that we could go back to the population, and if we could do survey of the population, then we would be able to understand what prevalence of the disease are. Now, for this, there are, of course, multiple different modalities people have invented, including building very large cohorts of individuals and then clinically assessing the entire cohort for different clinical phenotypes. But of course, that is not possible in a country like India because that would require enormous amount of resources to be able to do that. The other sort of cheap or alternative is to essentially look at their genomes of individuals and ask a very simple question. If you have 2 copies of chromosome, does your chromosomes carry genetic defects which you are a carrier of? And given the carrier status of individuals, you can sort of extrapolate that into population level prevalences. And given the population level prevalences, can we go back to clinics, educate clinicians on how to diagnose these conditions much better? Or in other words, can we also look at preemptive testing where individuals have not really developed this condition and be able to classify them as a diseased individual and manage them accordingly? Of course, that is not really possible for a lot of these disorders because unfortunately, many of these disorders do not yet have a treatment. Of course, the first disorder that I talked about does have a very effective treatment, but spinal ataxia, at least today, does not have a good treatment. But in the future, it is possible that with cell-based therapies and gene therapy, a significant large number of many of these diseases could be amenable to treatment. So to do that, until 2019, we never had the resources. While we did have the concept that you can look at a population scale unbiased genome sequence and ask a very simple question, what is the prevalence of a particular disorder? Now, that is not really easy because to do that, first you will need to get what are the genetic variants, or for that matter, what are the genes involved in a particular disorder. And given the number of genes involved in a particular disorder, you will need to go back to the variants in a particular disorder and take each of these variants, evaluate independently for the pathogenicity or evidence for pathogenicity. Now, to do that, there is a guideline available that is called the ACMG-AMP joint guideline. And what this guideline essentially means is that you can take any variant, you can reevaluate the evidence on this variant. The evidence comes in multiple different formats. They could come from experimental data sets, they could be ascertained from pedigrees, they could be coming from databases, they could be from very specific wet lab studies, they could be from disease association studies, and so on and so forth. In summary, you could take 28 attributes for each of this variant, systematically reclassify them based on the evidence. There's a scoring scheme for it. And based on the scoring scheme, classify into 5 classes: pathogenic, likely pathogenic, benign, likely benign, and VUS. Now, of course, this is a very painstaking effort, and therefore not many people have attempted doing this for any disease for that matter. But as clinicians, what I should recommend you is to actually be able to go back to these guidelines, because as clinicians who see genetic reports, it's almost always inevitable that you need to review the genetic report and the evidence on the genetic report. And of course, we do have now courses which can teach you how to reevaluate this evidence and the genetic evidence according to ACMG-AMP guidelines. But now, having said that, now we can do this for genes and disorders at scale. For dystonia, my colleague Dr. Binu Kumar has built one of the most comprehensive databases, which involves around 34,000 or genetic variants, each of them systematically reclassified according to the ACMG MP guidelines. Now that you can reclassify variants, you can now go back to population scale databases and ask a very simple question: what is the carrier frequency of a particular pathogenic variant or pathogenic variants in a particular gene, or all the variants associated with a particular genetic disorder? And ask a very simple question: given the carrier frequency, can I go back and estimate the population prevalence of many of these diseases? So in other words, what we can really do is use genomics and genomic data alone in conjunction with evidence that's already available in the literature to be able to ascertain population prevalences of many of these disorders that we today think is rare. Now, that also comes with this caveat that while we tend to do this based on evidence nomenclature, which I already talked about, the genetic dystonia nomenclatures, we should always keep in mind is that the clinical phenotype of movement disorders could overlap with many more other disorders. And this is what we learned the hard way, of course, by making a lot of mistakes. And we were very excited with this entire thing. We went back and built a cohort, and to our surprise, we did not find any patient with any one of the known dystonias. But what we found was even more surprising, that we did find a lot of patients with Wilson's disease. Now, Wilson's disease is also another rare entity by, of course, the prevalence estimates. And of course, there is enough literature to suggest that approximately 1/3 of patients with Wilson's disease primarily present with dystonia. And of course, the other primary presentation feature, which is really not well studied, is psychiatric manifestations. Now, this would necessarily mean that a primary approach of looking at the phenotype and our over-reliance on phenotype, and then looking for a genotype that can match the phenotype, can actually become a very wrong assumption to start with. So we did, of course, fortunately, with my colleague, go back to look at the population frequencies of Wilson's disease. And what we found was even more remarkable, that approximately 1% of Indians are a carrier for Wilson's disease, which roughly translates to 1 in every 40,000 births in this country would be a patient with Wilson's disease, and rarely diagnosed, rarely treated. And that is a real sad part, because Wilson's is a treatable condition with a very cost-effective treatment option available. So with my colleague, Dr. Binu, we built an entire cohort and methodologies to look at Wilson's disease, and not just that, to also screen Wilson's disease with a hope that in the future, we should have a newborn screening program for Wilson's disease, because given the prevalence, it really warrants screening for this disease in newborn. Now, having said all this, what should I also put in perspective is the world is changing around us, and that world is changing very, very fast around us. And one of the areas the world is changing extremely fast is in the area of genomics. Right? It is just around 2 decades that we have a whole human genome in terms of the reference human genome. And what happened in this last 2 decades is an enormous reduction in the cost of sequencing whole human genomes. We are pretty much today able to sequence a whole genome approximately around $400 or $500 odd. And in the future, we should expect to have sequences of whole genomes less than $100. It's already happening in many places across the world, and it will soon happen in India. And along with this cost reduction, there is also an enormous improvement in our understanding about clinical actionability or pathogenicity of genetic variants. And this knowledge repertoire has gone to exponential proportions over the last 1 decade. And that remains to say that while genome sequencing was an exotic or a research expedition in the past, it is already time that we can use this information to implement routine clinical workup in clinical settings. I've given you enough examples to say how genome sequencing can uncover otherwise undiagnosed genetic diseases, not rare uncovered genetic diseases, but using population perspective and population prevalences actually establish that these are not really rare conditions, but extremely prevalent conditions, at least in some populations. Now, that would necessarily mean that we should probably start rethinking the way we do genomics and the way we practice medicine. And the way we practice medicine is with a primary assumption with an over-reliance on clinical phenotypes, and we expect the patient to come to the hospital. But we should also keep in mind that when a patient comes to the hospital, that necessarily means that the patient has developed the disease. And in many of these cases, when the patients have developed the clinical features or the symptoms, it is already too late to treat these patients. Now, given the evidence of pathogenicity, and given that you have genomes and access to genomes, then you could really turn this around and say that you could screen apparently normal individuals, ideally at birth, and use the evidence that is growing exponentially over years to be able to ascertain, will this patient indeed develop this condition? And if you have enough evidence to say that the patient would develop this condition, which today you can, you would be able to intervene at that point in time and prevent the genetic disease from happening. The best example would be things like Wilson's disease, where there is enough evidence to suggest that you can screen the population for genetic markers. And given the genetic markers, you can predict who is going to have Wilson's disease. It's a treatable condition and therefore be able to treat them altogether. And more importantly, the genome sequence is constant from the day you're born to the day you're dead. And that would necessarily mean that any genome sequence sequenced today would have an enormous value over the lifetime of the individual. And as pediatricians, that would necessarily mean that every patient that you do a whole genome sequence today would be available to the patient to mine different kinds of information at different points in life of that particular individual. This could be right from the newborn stage to a childhood, to early adulthood, to career screening during the reproductive decision support, at the middle age looking at cancer predisposition, and old age looking at very specific genetic conditions which could affect your end of life. And all throughout the time also guide you to decide what kind of drugs you should get and what kind of dosage of drugs they should get and how to avoid adverse drug reactions. In other words that I would want to say is that the time for whole genomes have just arrived. It's already faster to do a whole genome than to do any other test. A whole genome today can look at all kinds of genetic mutations, all in one single test. It can look at single nucleotide changes, it can look at deletions, it can look at chromosomal abnormalities, it can even look at repeat expansion disorders. And therefore, it is really, really going to change the way we are going to practice medicine. And it's just time that is left to make it cheaper than any other genetic test, and the future is going to happen if it's not already happened. And that would necessarily mean that whole genomes would become the mainstay of diagnosis for undiagnosed or rare, apparently rare genetic conditions. I'll stop there and have only just few take-homes. The take-homes is that whole genomes can uncover a disease diagnosis if you don't have one, can estimate population prevalences and actually establish many of these supposedly rare conditions are not indeed rare. And individuals who today get the sequence can use this evidence and also future evidence over the lifetime. But what's really more important is to say that apart from the patients and persistence makes a lot of difference, not just in clinical settings, but also in research. Thank you very much.
Thank you, Dr. Manoj, for an amazing talk. I think, Mahesh, would you like to ask the experts to speak? Mahesh? Yeah.
Okay. Yeah. Thanks, Dr. Veena, for a wonderful talk. I'd like to request our expert for today to give their comments. We start with Dr. Vinod Goyal.
Vinay Goyal.
Yes.
Hello. Good evening, everybody. Wonderful talk, Dr. Vinod. And my impression was that SCA3 was commonest in ethnic Bengalis, what Dr. Kalyan Bhattacharya used to say. And in AIMS cohort, we had a very few small number of SCA3, but it looks like in your two of the case which you showed that they're coming from a particular place. So and there are two things. There is a lot of inbreeding happening. There's the marriages which are happening in the families. So that is one reason. But is it kind of a parent mutation which has happened, and that is percolating in the family, leading to such a large number of cohort from the same place?
Yeah, so that's a very fantastic question. And so to really put things into perspective, when we talk about India, we should talk about 4,000 endogamous groups. Now, these endogamous groups could be large, some of them ranging into tens of millions of people, and some of them are small, ranging into tens of thousands to tens of hundreds of people. But nevertheless, India is a constellation of 4,000 endogamous groups. That should really sink into your minds. Now, endogamous groups necessarily means that they marry within themselves, right? And this segregation could be based on caste, could be based on religion, could be based on ancestry, could be based on language, could be based on a number of weird things that we can never imagine of. But nevertheless, they marry among themselves. Now, by strict definition, they may not be consanguineous. Consanguinity necessarily means that you marry between your blood relatives. But given that these populations could be small, right, practically every marriage would be with a distant blood relative. And just because the founder events are small, the population is small, they may not be direct, evident blood relatives, but practically everybody that you marry within that same group could be your blood relative. Of course, you might argue saying that there are, of course, age-old systems and traditions and how we can avoid this, etc., etc. But in scientific parlance, that has no basis whatsoever. Now, the size of the population that would be at risk would be dependent upon how old is this mutation in the founder. Each of these populations have founder events, and practically you can say all these 4,000 populations do have founder events and founder diseases. And the age of the founder would necessarily determine how old or how large is the population at risk for this particular genetic disorder. Now, in this particular first community that I talked about, the founder is quite old. It's approximately around 200 odd generations. And that would mean that there's a significant large number of people who have that particular disorder, right? And if you find myoclonus, epilepsy, and tremor in any individual of that particular community across the world, rest assured that there is one test available that people can access and make a diagnosis. Now, you can take any community across the country, right? I can tell you, and at least one disease which is prevalent in that community. Right? Now, if you go historically to this, all of these endogamy events are extremely recent entities. The history of endogamy and history of caste system is only approximately around 2,000 to 3,000 years old, right? And that's a very recent entity. So what has really happened is that there have been migrations to India, and in the very recent, what they call event, there have been a sort of segregation of people into different groups based on caste, creed, religion, etc., etc. And then started this concept of endogamy. We don't really understand how and where did this concept of endogamy start, but nevertheless, it started, and this is a very recent event, approximately 2,000 to 3,000 years. So practically all the populations that we sort of talk here, of course, with some exceptions, these events are with founder mutations, and these founder mutations are approximately 2,000 to 3,000 years old. Right? Now, some populations, of course, do have much older founder events, and they also come with a tradition, history of migration, etc., and records to sort of prove so. And therefore, they have much larger population size, which is at risk. Hope that answers the question.
Yeah, thank you. You can make out from my name, I am Goel and I am Agrawal. And the ancestry of Agrawal goes 5,000 years old. What
Right.
Agrawal starts from Maharaja Agrawal, we are their descendants.
Right.
SCA 12, we all of us know, is very common in Agrawal.
Absolutely.
But I'm not sure whether everybody knows this. So there are 18 Gotra in Agrawal. So there were 18 children of Maharaja Agrawal who they follow. The ritual used to be when you marry, you don't marry with a girl or a boy you used to leave 4 gotra: your father's gotra, your mother's gotra, and your grandparents on either side. So these 4 gotra were supposed to be escaped for a marriage. That was the ideal marriage proposal in Agarwal. But over the period of time, it became very difficult to find even an Agarwal boy, what to talk of a different gotra. And that's how I think this is my presumption, and I may be very wrong. I see a lot of, now I see almost every 2 weeks I see one SU12. Though I'm in practice, and I was not seeing that much in the government sector, and our AIMS data has shown that probably SCO12 is one of the largest of the spinocerebellar ataxias. But that also may be because you get pulled up at AIMS. That is one reason.
Yeah, absolutely. You are absolutely right in that, saying that, see, there's always a bias in that ascertainment, because if a clinician or if a center tends to diagnose a particular disease better, the patients eventually will end up being in that center, right?
Correct.
Either by referral or by word of mouth. Now, the founder events and marriage doesn't really work for autosomal dominant conditions. Spinocerebellar ataxia type 12 is a dominant condition. Typically, that doesn't you cannot really get rid of by marrying outside the community, right?
Yes.
Because it's a dominant condition.
Yes.
But in Bansal Agarwal community, there is another recessive founder event, which is for cystic megalencephaly. I did talk about that condition in one of the previous talks.
Yes.
Right?
Yes.
It's a recessive condition, and the founder mutation was actually discovered in AIMS.
Yes.
And it's called the Vandernapp mutation.
It was done by Dr. B.S. Singhal, who I think initially described some of the cases in collaboration with Dr. Vandernapp.
Right.
Other condition is dysphalinopathy.
Absolutely.
It has also been seen in Agarwal community as one of the factors that they are running. I don't know the detail of this, but they are running into. Agarwal, maybe Jain also. They
Jain
have this
also.
gene which is percolating. Your talk is very interesting, but today I had a very interesting case. This gentleman was diagnosed at multiple places as amyotrophic lateral sclerosis. Adult onset, maybe 45, 50-year-old gentleman. For last 6 years, he's been progressive like ALS. And somebody said, why don't you do in genetics? And I think they did clinical exome sequencing, which came out with 2 genes. One is spinocerebellar ataxia of type 43. Patient, I've called him to see myself because I saw it video consultation. I don't think patient has any ataxia. Other thing was Park 8, and patient doesn't have Parkinsonian feature. So, we are ordering exome sequencing left and right without knowing that what exactly is going to be outcome. Now, what do I do? Should I treat him as ALS? Should I treat him as Parkinson? Or should I treat him as ataxia where he doesn't have ataxia? And
Yeah, so
patient's question is, what do I have? ALS, Parkinson, or this? So how do you
so that's it.
My question is
So
to you.
it's a very common problem.
Yes.
I'm sure everybody who has done genetic testing has come across this problem. And I'll tell you what this problem is all about.
Yeah.
This problem is all about because practically all the genetic evidence that is in the databases are from one of the labs abroad, right? And typically what happens is, I'll give you an example of Wilson's disease because many of those variants I've reclassified myself.
Yes.
There would be a paper, for example, from the UK, which says that this particular variant is associated with Wilson's disease.
Correct.
Right? And that goes into the database and that percolates everywhere. Right?
Oh.
There's a publication, that publication goes into the database, somebody has collected it, curated it, and made it into a pathogenic. Right? Now, when we did the population scale genome sequencing, we identified that many of those variants are actually polymorph. They are in 10% of people, 20% of people. That is very unlikely to happen. So we actually went back to some publication. We actually, in some cases, contacted the primary investigator to actually reveal what was the ancestry of that particular individual. Right?
Yes.
Now, this is largely stemming from the fact that suppose an Indian lab or Indian clinician send a sample of Wilson's disease to a lab in UK.
Yeah.
Right? The clinician is going to write, say, test for Wilson's syndrome or Wilson's disease. The lab is going to sequence ATP7A or 7D rather, and If there is a mutation that sort of looks like pathogenic, that guy is going to report saying that this is a pathogenic mutation that I have found, and the report is issued.
Yes.
The patient indeed might have a different disorder altogether.
Correct.
Right? So there is a bias in ascertainment that comes through.
Uh,
Now, once this percolates back, practically all exome sequencing that you do is largely based on one of these databases.
yes.
The reporting is largely based on this database. And that's why I exactly said that as clinicians, if there is one skill set that you need to learn, it is to learn how to reclassify variants according to the ACMG MP guidelines. If you can do that, I'll say that most of those variants would be polymorphic in Indian population and very unlikely to have caused the disease. Right?
I had a very interesting 35-year-old young man, 3 years asymmetrical progressive Parkinsonism. I would diagnose him as young onset Parkinson. I would never do genetics. When he came, he said he had tried levodopa and levodopa is worsening his condition. I said, this is not like Parkinson. And his progression in 3 years was too fast to call it a Parkinson. So I said, do a genetic test. To my surprise, it came out to be DYT27, which is extremely rare dystonic disorder. And that can explain all these things. But point was, there was another mutation which was like this spastic paraplegia, what you call HSP, hereditary spastic paraplegia, sometime 56 or 46, I don't remember the number. The question is, which one to believe now?
You need to reevaluate it independently. Reevaluate the evidence independently.
Clinically, to me, it's like a Parkinsonian syndrome and not responding to levodopa. I would plan to do DBS. Now, when he came with this report, because he did another test, I said, if it is the HSP, I don't want to do DBS in this case. So now the dilemma, there is no litmus test to find out which is the right gene causing phenotypic expression.
No, there is a litmus test. It is to just reevaluate the evidence based on the ACMG MP guidelines. If you have enough evidence to call it as pathogenic, you should act upon it.
Okay.
Vinay and Vinod, excellent discussion. And Vinod, may I just add, I think to that we were making a platform in which, between the COA and you guys, and that we can have all the VUS shared, and then we'll be discussed and get the informatics thing. And now I would request basically Dr. Sanem from Turkey and Dr. Tajul from Malaysia to share their confusion in such situations, in addition to what Vinay has been saying. Please, Dr. Sanem, please.
Many thanks to Dr. Vino for this wonderful talk. I was really very impressed about all the cases, but I was really impressed with the cases with SAMD 12 triplet repeat expansions. I'd like to ask your opinion about these cases because in pediatric neurology clinical practice, actually we have some patients with clinical picture as progressive myoclonic epilepsies, including cortical tremor, myoclonus, and some intellectual disabilities. And although we use many metabolic and genetic studies, sometimes they all come back to normal results. And in which clinical situations, including progressive myoclonic epilepsies, Dr. Vino, you suggest about thinking the possibility of this triplet expansion disease? And also these cases reminded me about the Unverricht-Lundborg disease. Most of these cases are caused by dodecomeric expansions in the cystatin B gene. Sometimes even we try to study this gene, and it also comes back normal. So what do you suggest for pediatric neurologists about this condition? And also I'd like to ask if you have any experience about the autosomal recessive cases, because as soon as I read, I think there are more younger cases with more severe phenotype if the disease is inherited in a recessive pattern. Thank you so much.
Yeah, thank you very much for that very specific question. So most of the ataxia phenotypes, which are associated with triplet repeat expansion or even pentanucleotide repeat expansion, are typically autosomal dominant. Of course, there are recessive varieties, but rarer varieties. So if there is a familial autosomal dominant kind of pattern, you should surely go back and do the genetic testing for it. Now, why did we miss out this variant for ages altogether? Is largely because the standard of genetic testing, which is either a clinical exome or a whole exome sequencing, cannot identify repeat expansions. The gold standard for repeat expansions is to use a repeat primed PCR that was in the past, or today use a whole genome sequencing. Now, the problem with repeat prime PCR is that there are very few labs, even across the world, who are doing repeat expansions because it's a very tricky test to start with and not really amenable for wide scale application. And so therefore, very few labs are actually doing repeat expansion, even for the commoner repeat expansion disorders. There are many more loci in the genome which are prone to repeat expansions, and we still do not, I would say, know about many of these disorders and their genetic locus yet. SAMD12, we were just lucky that we were looking for that particular gene, and we found that particular repeat expansion after almost 4 years of frustration, because you can really think of the frustration of a geneticist, right, not able to find a variant in an autosomal dominant condition, right? Because autosomal dominant condition is something that people think is very easy to crack. Recessive conditions are much difficult to crack. Autosomal dominant condition is much easier to crack. And despite having multiple individuals in the family, clearly knowing that it's a genetic condition, we could not crack it. And that is really frustrating. But whole genome sequencing allows you to do that because it covers a wide variety of genetic markers or genetic variants, which are typically not covered in individual tests, right? So if you have a familial case, then very sure you should go and do a genetic testing. Now, repeat expansions also come with this interesting phenomenon called anticipation. That means that every generation forward, the onset of disorder is going to be earlier. So, for example, for SAMD12, we do have 8-year-old children with the repeat expansion. Otherwise, the age of onset was approximately around 40 years. But with every new generation, the age of onset is going to reduce further. And of course, they're going to end up with more severe conditions. So this is something that we should also keep in mind, that like triplet repeat expansions, pentanucleotide repeat expansions, or rather all repeat expansion disorders typically come with this additional phenomenon called anticipation, where the children would have an earlier and more severe onset of the disease than their parents.
Okay, thank you. What about your opinion about the SAMD12 gene with interest to this gene?
Yes, so SAMD is one of the pentanucleotide expansion disorder genes. There are now many more genes discovered in the last 5 years.
And how did you design the PCR, real-time PCR for this gene?
Yeah, by going back and looking at the gene locus, since from the gene locus we knew that it is likely a pentanucleotide expansion, we could go back and design that very specific primer, as I sort of showed in my slide. So the principle of designing it is very simple. You put one primer, which is the repeat. So you have 4 primers, P1, P2, P3, and P4. The P2 and P4 are on the primer, which is on the expansion, which is TTTA and TTTCA. The TTTA is the wild type and TTTCA is the expanded repeat. So it's a mutation plus an expansion. And you have P1 and P3, which are in the non-repeat regions, right? So when you run this PCR, right, if you have a repeat expansion in this particular TTTCA, along with, so P4 and P3 will have multiple copies depending upon the size of the expansion. While the non-expanded wild type, which is TTTA and P1, that's P1 and P2, will have only one copy, right? Now, when you run it on a gel, you should be able to see such peaks. And when you see such a peak, that means that the repeat is expanded. So you can go to the locus and design these PCR primers and be able to do this assay.
Okay. Thank you.
Dr. Sajal, your comments, please. Dr. Tajan?
Yes. Thank you. And congratulations, Dr. Vinod, for such a mesmerizing talk. And as always, so I just have one comment and probably one question. So my comment basically is based on my clinical experience, such that most of our cases of pediatric movement disorders are they present in a more complex manner, such that the phenotypes or the phenomenology itself overlap. Either they present in a more simultaneous manner or in such a sequential manner, maybe in the same patient or in the same family members. And they may coincide with certain neurodevelopmental issues, which may not be present with in other family members. So phenotyping is probably most important aspect in making a diagnosis of a child before going ahead with any genetic testing, because reverse phenotyping can be beneficial or at the same time can be very detrimental or misleading to us. So that's my comment. My question is, this is something that I've always wondered, and probably because of my lack of knowledge in genetics, I've not really got an answer for that. How do you explain this? I've got this, for example, I've got a family of CACNA 1A, and one boy has got EA2 phenotype, presents with episodic ataxia, and he's fairly well with no, at least at this point of time, with no degenerative changes and no progressive ataxia. The other boy has presented with, both of them are boys, and this is a family of 2 boys and 1 girl. And the other boy is presenting with very frequent hemiplegic migraine phenotype. So, I mean, for a non-geneticist like me, myself and many others out there, how would you put this in the most simplest words to explain this peculiarity or this occurrence?
Right. So the answer of this is something what we call as modifier. Right. A modifier necessarily means that apart from the pathogenic genetic variant or variants that cause the disease, you have additional mutations in the same gene or in the same pathway, which can make the disease worse or make the disease less worse. And that depends upon how the pathway functions, either by supplementing part of the pathway components or by depleting parts of the pathway components. Now, in simplistic terms, if you want to say, I would say, take the case of sickle cell anemia, right? I ask everybody in sickle cell anemia, you will say that if you have a homozygous HBS variant, then you will have sickle cell anemia, right? And that is the basic principle of screening for sickle cell anemia. That's also the basic principle of offering genetic counseling and prenatal testing for sickle cell anemia. But what I can tell you as a matter of fact is that not all patients with homozygous HBS will have sickle cell disease. There is an additional genetic modifier in this particular case, which is one of which is very prevalent in the population. Approximately 3% of Indian population has it. Is a condition called hereditary persistence of fetal hemoglobin. So they do have sickle hemoglobin. They also have a small level of fetal hemoglobin, which prevents the sickling altogether. So they do have a genetic disease by genetic patterns. They have sickle cell disease by genetic diagnosis, but they also have an additional genetic deletion in the HPF locus, which will activate the fetal hemoglobin. The child is not supposed to have fetal hemoglobin. It's supposed to be only in the fetal period of time. But since the regulator is lost, it produces fetal hemoglobin to small extent, 10 to 15%. And that 10 to 15% of fetal hemoglobin is enough to prevent the sickling of fetal hemoglobin, and therefore they will not manifest a disease. And 3% of Indian population has this quite innocuous otherwise activation of fetal hemoglobin, right? In a normal individual, this is very innocuous, but when it coincides with a sickle cell homozygosity, it prevents the disease onset, right? So these are called modifier locus, and modifier locus can act in both ways.
So if I got you right, these modifying genes may influence the phenotype of presentation as well, or the severity of the presentation.
Absolutely.
So can they also modify or determine the manifestors and non-manifestors?
Absolutely.
Okay. Thank you. Thank you.
Thank you, Dr. Taj. Dr. Anaita, would you like to make some observation and comments? before Mahesh goes through the Q&A? Dr. Anayata?
No, I just thought it was an excellent talk. I think the biggest concern we all have is interpreting the VUS. And I think as we grow, and as you said, our knowledge of genetics is growing, but is still very limited. And this reverse phenotyping, as found, is a very important aspect for us before we counsel and before we actually label a patient with a genetic disorder. Thank you so much for an excellent session and for a brilliant Q&A session from everyone.
Thank you. Thank you, Dr. Anayata. Mahesh, can you go through the Q&A?
There are some questions now. Dr. Vinod, Dr. Ranjit from Chennai has asked a question. How can we get SAMD12 gene test done for clinical purpose?
Yeah, so there are two ways you can access SAMD12 genetic testing. One, you can contact Dr. Radha Mahadevan. I can share the contact details. Or you can approach IGIB. IGIB does this genetic testing in the lab of Dr. Mohammad Farooq, who was my former colleague. And both the tests are free of cost.
Thank you. One more question, I think it's a very common question. Please say something on reclassification of VOs, how to go.
Reclassification of VUS. Okay. So I'll just probably pull out the slide once again. Yeah, so what essentially you do, not just for VUS, but practically every variant that you come across, there is a guideline that is available, which essentially states that every variant has to be deconvoluted into 28 attributes. And these attributes come from different sizes and forms, either from databases, from literature evidence, from experimental studies, from family pedigrees, in terms of segregation, in terms of disease association studies, in terms of frequency of that particular mutation, so on and so forth. Each of this parameter has a particular score. You add up that score, or there's an algorithm to add up that score. And given a particular combination of scores, you would be able to classify into these 5 categories. Now, VUS by definition means that you don't have enough evidence to either classify it as benign, or you don't have enough evidence to also classify it as pathogenic. That means that for want of evidence, I don't have a class to fit into. Now, there are 2 ways that clinicians can help classify it, either in the pathogenic side or into the benign side. This is largely by 2 approaches. The first approach is to have a system where they can ask around who else has got this particular genetic variant. If you have got another patient, which is very likely, given that we are a small country and a small number of clinicians doing these things, if there's a system to ask around, have you ever come across this particular variant? And does the phenotype match what I see in my patient? That is a fairly good possibility that you will find another patient with the same phenotype, with the same variant. And then by loss of segregation, you should be able to classify it as pathogenic. The other approach is to, of course, sit through the entire evidence process, or do actually collaborate with a researcher who can do those experiments to prove that particular variant is pathogenic or not pathogenic or rather benign. Now, these are the largely 2 approaches to do. In India, we have a third advantage, that we have access to large families, which the rest of the world does not have access to. So if we can sort of draw extended pedigrees and screen additional family members in such large families, especially from endogamous communities, that becomes an extremely useful tool to classify it as a likely pathogenic or likely benign, right? But never be under the assumption that a database is going to reclassify them. Either you're going to reclassify them by looking at evidence or sifting through evidence, or you're going to study extended family pedigrees, or you're going to collaborate with somebody who can do that experiment to prove it is right or wrong. There's no other way.
One more question, are triplet prime PCR and repeat prime PCR the same?
Yeah, triplet prime PCR and repeat prime PCR are the same. Triplet prime PCR only look for triplet repeats, but a more generic term would be to say a repeat prime PCR. The repeats could be coming in multiple sizes. So you could have a pentanucleotide repeat, for example. So it's a more generic term which encompasses all kinds of repeats.
One more question from Dr. Mohammed. How weak clinician can get training on genetics?
Very interesting question. So there are multiple ways you can get trained in genetics. We do have an extensive online course, 16 weeks, which train you on the basics of genetics, how to go about ACMG, AMP, classification, annotation, etc., etc. There is also a YouTube channel which you can follow at your own leisure and time, which explains all these concepts in very simple terms and language. I can share the links of both after the session.
I'm done with the questions. So,
I think before Vinod will give us take-home messages, I will request the experts to give take-home messages. Dr. Vinay, your take-home message.
I have a little more clinical question. Dr. Vinod, the anticipation in trinucleotides versus tetra or pentanucleotide repeat, which has a higher anticipation?
No, so anticipation largely depends upon the gene and the effect
Dr.
of
Vinod,
the
you can stop
recessive to the-
sharing. You can stop sharing so that
Yeah,
you're
sorry,
seen on
sorry,
full screen.
sorry.
No, you're seen
sorry.
fully.
Yeah, sorry. Yeah, so the anticipation largely depends upon the gene. So it's a denominator of the gene to start with, and what is the kind of function that the repeat expansion does. In this particular case, the repeat expansion is an intronic repeat expansion, and it affects the RNA folding and RNA splicing to start with. But different repeat expansions, depending upon the site of origin in different genes, could have different functions. And the anticipation is therefore also a factor of that particular function.
This is more technical answer, but for example, I give you, like in spinocerebellar ataxia, the average anticipation is 5 to 10 years from the previous generation. So there is a case of pentanucleotide. Is it the same age gap?
Approximately the same. Approximately the same.
Okay, fine. I'm done with Dr. Shefali.
No, Dr. Vinay, you have to give take-home message. This was your query.
Okay.
Your take-home message. So it's not so simple.
Yeah. My take-home message is always use genetics very judicially. Because now it's available at 10,000, 15,000, 20,000 rupees cost. And problem for clinician is because I work as a tertiary level center, people will come with a genetics report and now they don't want to show you the patient. They say कि हमारे पास genetics का report है, which is a very disheartening thing. Like the case which I saw today, ऐसे पहले आप मुझे केस दिखाइए. तो मैं आजकल सबको एक एग्जांपल देता हूँ कि जब तक आप मुझे लड़का नहीं दिखाएंगे हम आगे शादी की बात नहीं करेंगे.
Dr. Vinay, we have different countries, so you can talk in English.
Oh, yeah.
Sorry.
So the example I give is until unless you show me the boy, I'll not talk about marriage. So first show me the case. Let me see the case clinically. Then I'll look into your genetics report, which whether it's correlating or not correlating very well.
Thank you. Dr. Sanim, take home message from.
Thank you. My take-home message is, I think whole genome sequencing is going to be the solution of many unsolved cases in scientific area. But in daily clinical practice, the child neurologist should always think about the clinical picture and cost effectivity of the genetics tests. So we should always think about the patient's clinical picture and choose the right genetic analysis that will take us to the diagnosis. Thank you.
Thank you so much. Dr. Taj.
Thank you. So my take-home message. So in this current era where we are discovering more phenotypic variability and genetic heterogeneity, I think we have to exercise great caution in trying to make a diagnosis just based on one aspect. I mean, genetic testing, whole exome sequencing, targeted exome sequencing is a fantastic tool, but like what Dr. Vinay has mentioned, we have to use it very judiciously. Thank you.
Thank you. Before Dr. Vinod gives the final, Dr. Anayata and any other SIG member who would like to say. Dr. Anayata, you please give a take-home message, and Rachna and others, the SIG members will also think about take-home messages. Yeah.
I personally
Dr.
think
Anayata.
this genetics is like a study in progress. We were very enthusiastic and rapid to start with it in the beginning, but I think the more we see it and the more we learn, we realize there's a lot more that we need to know, and it's not as clear-cut as just getting a report. So I agree with Dr. Vinod. We need to be very careful, go in a sequential order, before we run to do a genetic test and understand the consequences when the test comes and it doesn't give us or it gives us something else.
Thank you. Rachna, then Mahesh, and then comes to Vinod for final. Dr. Rachna?
Yeah, good evening, everyone, and thank you, Dr. Vinod, for really enlightening us. And this is something which we always stumble on, as Dr. Anayata also mentioned. And yes, I do agree, like, being sequential matters a lot. I would just recollect something like, we kept working up so much and so hard biochemically and genetically as well. And ultimately, the boy ended up having a microdeletion, which was giving a lot of dyskinesia and movement issues. So something like, which turned totally full circle. And where we had been really investigating all neurotransmitters and everything. So yes, being sequential, reviewing, and it does matter. And US will really unfold in future, and maybe we'll have some common pathway. Yeah, thank you so much.
Thank you. Ranjit, you were there. You want to say something? Ranjit?
Hi, ma'am.
Hi.
Yeah. So, like, it was really fascinating to hear that SAMDH12 story. The Nodar community is like now spread across the world, and they have actually moved to other cities, including Chennai, and they own a lot of grocery shops. So every grocery shop in Chennai is actually run by another community. So that is the one I just wanted to tell. Thanks, Dr. Vinod, for an excellent talk.
Mahesh?
Thank you.
Yes. I agree with all the experts. First, we need to have clinical diagnosis first, and then depending upon the genes on the report, we do a careful reverse phenotyping. And then the institutes of the US, we need to collaborate and keep looking at the literature. Only then we can solve these genetic problems in
Thank you. And I think I will ask Vinod that we should give them a date when we launch that platform we've been talking about.
Sure.
And before that, I
Sure.
want to ask a question to Dr. Tajul. Dr. Tajul, I think you must be having the maximum experience, the maximum clinical N experience on movement disorders. Just tell me, tell us how many percentage would have been helped by genetics,
I mean, at this point of time, when we are moving from the era of it is suffice to just make a clinical diagnosis and start a treatment, but patients asking, have you confirmed the diagnosis? At those days, the answer for that question is yes, I've confirmed based on the clinical phenotype. But now you have an ancillary test, which has become more paramount than the clinical diagnosis itself. So in majority of the cases where patients are affordable and the avenue is available, I go for genetic testing. What I've learned over these years is the phenotyping, the phenomenology for movement disorders, is very important. When you phenotype them right, your VUS can be likely pathogenic or pathogenic. But if you don't phenotype them right, for a different form of phenomenology, it usually comes out at VUS, or you'll have a few VUSs here and there. So probably, as everybody has mentioned, I would say for me, at the first run, probably 40 to 50%, it would help me in making a clinical diagnosis and also a genetic diagnosis. Second run, probably slightly higher than that.
Dr. Sanem, what about you? How many percentage of cases would have helped, in movement disorders, genetics?
I think in our clinical practice, maybe 20 or 30% of cases can be diagnosed.
Thank you. Thank you. And I think message which we should carry for pediatric neurologist and neurologist is even in 2024, your clinical history and examination has to be done, and it will not be replaced by any genetic testing. The genetic testing, they also, when they are doing and checking up with all of them, the clinical features and the phenotyping, whatever you get, is going to guide it further. And that's very important. And Dr. Vinod, it's all up to you to give the final take-home messages?
Yeah, I think I have just 3 points to make. The first point is that many disorders that we consider as rare are not indeed rare. The second point I think to make is we are at the cusp of the change where we believe that patients will come to clinicians and clinicians will make a diagnosis, but rather screen for a high evidence prevalent genetic mutation, especially for treatable conditions, would prevent the disease from starting altogether. I think that is the opportunity that we have. The third, in India, very specifically, the opportunity that we have is that since many of these disorders are in communities and they have founder events, there's a fantastic opportunity to make the genetic evidence cheap, affordable to the entire community. You don't need to do a whole genome sequencing anymore for the NADAR population, or you don't need to do a whole genome sequencing anymore for SCA12. Because if you know that the patient comes from the Agarwal community, you exactly know what is the test that you need to administer. That is an opportunity that we have in India if we can work together for it. Thank you.
Thank you so much. And thank you all for joining. And it was an amazing talk. And I think it's very important. And next week we come with an excellent presentation and talk by Dr. Tajul. Yeah, see you again next week. And thank you so much. And all of the presentations are available in the YouTube channel and everything is recorded. So one can, I didn't ask you for permission because you have been our old faculty. So you are always permitting. Yeah. So I took the liberty. Yeah. Thank you so much. Thank you, everyone. Thanks a
Thank
lot.
you, ma'am.
Thank
See
you very
next
much.
week.
Thank you for the
Thank you very much.
Bye-bye.
Thank you very much.
Thank you. Thank you. Bye.
Thank you. Bye.
Thanks. Bye. Bye.